Okay, so our aim was to reduce constipation harm associated with opioid use on 6 North Ward by 25% by June 2016. So we were a bit late starting this. I think, as you remember from learning session 1 and 2, we were originally focused on reducing fentanyl use. But we found that through our ADE and GTT data that constipation harm was our biggest problem. And when we did an audit, we found that those patients who were on 6 North Ward, yes, there we go, which was an orthopaedic surgical ward. Oh, goodness. This isn't an intervention. We have been quite busy and we are at the point of being able to test some of the things we want to try. But we have regularly been monitoring our bowels to see if they've moved in the last 24 hours and documented on the patient admission to discharge plan. So fortunately we have a PADP, as we call it, an A3 care plan, and we are required to monitor patients' bowels on that plan, and that's worked very well for us. It's required the efforts of the clinical nurse specialist on 6 North Ward to do an audit of 5 patients per week, and that's how we collect our data. And this is just a picture of our communication board. We ran a competition to have a name for our project, and the winner was from one of our house surgeons. So our project is called No Pain and No Strain. What the data is showing, and this isn't statistically significant, but we have had an improvement in monitoring our patients' bowels through the PADP. And we are also collecting data through the audit each week on patients that are co-prescribed laxatives but also given those laxatives. So we haven't pushed this, but we are showing a little bit of a difference. And our constipation harms are in the control chart below. So our definition of constipation, opioid constipation harm is bowels not open greater than 72 hours. And I'll let Janice present the rest.
Thanks, Caroline. So one of the things we did do as a baseline was took a survey of our nursing staff just to really see what people thought, and it was quite interesting. It showed that they knew that constipation was a problem in that area. They definitely knew what they should be doing, but no one knew why they should be doing it, so no one really understood what the laxatives were. So that's going to be a target of where we're going with regards to our education. And so we're going to look at our RMOs as well to see whether or not it's a similar problem, and just from conversations it sounds similar, that I think everyone knows and acknowledges there is a problem, but no one knows what they should be prescribing when and why you should choose certain laxatives. So it's just some of our key lessons and achievements. Just through doing the audit and of the bowels not open and whether or not that's documented and just starting the conversation, that seems to have had a positive impact, and we seem to have had a bit more compliance with regards to giving laxatives, and there's been a little bit of an impact on our constipation overall. Like I said, from our staff survey, we know that people can't know what they should be doing, but they don't really know why. And like I said, we're going to look at the RMOs next. We have had confirmed best practice for our DHB as to what we want everyone to do, using both a softener and a stimulant. So the next steps will be kind of where we go from there and how we get that message across in a consistent way. And one of the interesting things was we've got a constipation leaflet that we've modelled on, I can't remember whose, so thank you whoever the DHB was, counties, that we have modelled our constipation information on. We tried to make it really succinct, and we tried to make it one side of A4 because that's what we thought patients wanted, but when we actually asked them, they wanted more information. So it's actually ended up being 2 sides of A4 with a lot of information about the actual laxatives on it, so that was a really interesting learning for us. So that's just a copy of what we ended up with, which again, it was quite lengthy, but that's what the patients actually wanted when we asked them. So struggles are kind of similar, I think, to other people. Finding medical staff with the time and ability to join the group was really difficult, especially RMOs who are often changing, but we do have 2 that are dedicated to that now. And we had quite a bit of pushback, and I don't know whether or not anyone else found that. When we approached our senior orthopaedic surgeons, they said that they were getting lots of soiling in theatre because we're giving too many laxatives. So that has really delayed our progress, because not being able to get our orthopaedic clinicians on board has been a bit difficult. So I'd be really interested to know if anyone else had had that kind of problem. We have found it was really difficult because they couldn't quantify it at all. It was just that it just happened. But we have tried to look back, and it seems it's not as much as we were told. But it only takes one for there to be a negative impact. So we're managing that. But it was really good. Our staff have been really good and engaged, and everyone wants to help. So we do have an engaged area, so onwards and upwards from here, and it's really interesting to see what everyone else has been doing so that we can take some of that back and try and implement that. So I think that's our story. Thanks.
Thank you.